for inviting me to be here. It's really challenging, to follow a talk after Dr. Rajadhar and an excellent talk by Dr. Usha also. But the good thing is that they both have done my job very, very easy. A lot of things that I was supposed to sit and explain, now it's going to be a revision for y'all. So I'm going to be talking about something which is extremely exciting and interesting. One of the topics in sleep which is very close to my heart because I think it's really interesting. So I'm going to be talking today about obesity hypoventilation syndrome. So when we say that obesity hypoventilation syndrome is present, three criteria have to be met with. Number one, the patient has to be obese. The name is very easy, obesity hypoventilation syndrome. So the first criteria is that the patient has to be obese. That means the BMI has to be more than 30. The second thing is hypoventilation. So the patient is supposed to have chronic alveolar hypoventilation also when the patient is awake. So it is not only sleep-related hypoventilation, but it is also awake alveolar hypoventilation. And therefore, when the patient is awake, the ABG will show that either the PCO2 is more than 45 or the PO2 is more than 70 or both. So this is the second part. And the third part is we are talking about sleep. So it's supposed to have sleep disordered breathing. So OHS, very, very easy. The definition, three criteria, obesity, BMI more than 30, awake chronic alveolar hyperventilation so that PCO2 is more than 45 and PO2 is less than 70 on room air when patient is awake. And third, patient has presence of sleep disordered breathing. But of course, we have to make sure that certain other conditions which also give rise to these features are ruled out. For example, patient should not be having kyphoscoliosis, patient should not be having severe obstructive restrictive disorders, patient should not be having central hypoventilation. So if these things are present, they have to be rectified. You have to treat the patient. Despite that, if these things present, then only you say that the patient has obesity hypoventilation syndrome. So basically, medically, we doctors came to know that this syndrome exists from 1956. And that time, it was known as Pickwickian syndrome. But what is really interesting is that before we doctors made out, we had Charles Dickens. I don't know if you all have heard about him, but we grew up reading his novels. So Charles Dickens realized 120 years before we doctors identified that there was an entity like obesity hyperventilation syndrome. And in his posthumous papers of Pickwickian Club, he actually describes the fat boy Joe. He was fat, he was all the time sleeping, and when he was sleeping, he was snoring loudly, and he was actually choking. So basically, this fat boy Joe actually was a Pickwickian person, and basically the name of Pickwickian syndrome we have actually borrowed from Charles Dickens. So the thing is that this fat boy, he had all the features of obesity hyperventilation syndrome in the form of he being fat, he snoring, he being drowsy, and he having witnessed apneas. So basically, this is what obesity hyperventilation syndrome consists of, and it is also known as Pickwickian syndrome. So basically, we said that obesity hyperventilation syndrome patients have sleep disordered breathing. So it has been found that 90% of patients have obstructive sleep apnea and 10% of patients of obesity hyperventilation syndrome have central sleep hypoventilation. That means 90% of these patients, when they are sleeping, they are actually choking and they have obstructive sleep apnea. But 10% actually have pure sleep hypoventilation. So what do we mean by sleep hypoventilation? So if you do a patient's ABG and if the PCO2 is 46 when awake, and when the patient goes to sleep and you do an ABG, and if the PCO2 increases by 10 or more, that means PCO2 which was 46 while awake becomes 56 or more, then this is diagnostic of sleep hypoventilation. Also, if the patient has sleep hypoventilation, then during sleep study, patient should not be having apneas or hypopneas, but despite that, there is desaturation. So if these two things are happening, then we diagnose this patient to be having central hypoventilation. So what is important is that untreated obesity hypoventilation syndrome is a progressive disorder and is associated with increasing cardiovascular morbidity and mortality, and therefore its prompt recognition and treatment is critical. So what is the prevalence of obesity hypoventilation syndrome? So prevalence differs based on what population you're looking at. So if we talk about general population, then the prevalence is quite small. Only 0.15 to 0.3% of general population has obesity hypoventilation syndrome. But if we look at obese population, then it has been found that the prevalence of OHS is pretty significant. And one of the studies actually showed that if the patient's BMI was between 30 to 35, then the prevalence of OHS in these patients was 8 to 12%. If the BMI was more than 40, then the prevalence increased to 18 to 31%. And a patient whose BMI is 50 or more, the prevalence of these patients having OHS is as high as 50%. So whenever we see obese patients, even if they have typical obstructive sleep apnea, please think that this patient could be having OHS over and above, and we need to treat these patients differently because the cardiovascular complications of OHS are far worse than those seen in obstructive sleep apnea. If we look at patients who have OSA, so the patients who have just the symptoms of OSA are referred for sleep study, 16% of these patients actually have OHS. And patients who have documented severe obstructive sleep apnea, whose AHI is more than 60, 20 to 30% of these patients have coexisting OHS. So what I just want to tell you is that we just finding OSA is not enough. We have to specifically see if these people have OHS over and above. What is interesting is that when patients who are hospitalized, who present with type 2 respiratory failure, whose BMI is more than 35, it was found that 31% of these patients actually had obesity hypoventilation syndrome. So these patients are multiple times they are admitted in the hospital, but the diagnosis of OHS is always missed. They are diagnosed as either COPD or OSA, they are treated, they go home also. But the diagnosis of OHS is always missed despite multiple admissions. And only when they reach 5th to 6th decade of life are we making this diagnosis. And fortunately for us, this diagnosis finally is made when these patients are referred to pulmonologists or critical care specialists. So the thing is that we are the ones who are looked upon to diagnose this condition, and therefore we have to really look for it. Ethnic factors also play an important role, and it has been seen that Japanese have less amount of prevalence of OHS, though their weight is more, as against African American patients who have a much higher incidence of OHS. Okay, so what exactly happens in OHS? So as the name suggests, obesity is the main culprit. So BMI more than 30, and especially if BMI is more than 50, then this patient has a very high chance of getting OHS. The mechanism is not exactly known, but there are multiple factors which are thought to be giving rise to OHS. So basically the most important thing we as pulmonologists need to understand is that fat people have adipose tissue all over the body. So there's excessive fat on the chest wall, they have excessive fat on the abdomen, and as a result of that they're going to press on the lungs, and this will give rise to restriction. Therefore the compliance of the lung will be reduced, and as a result of that there will be increased strain on the respiratory muscles. They will be working, they will be in action all the time, and therefore this results in respiratory muscle fatigue. This is what happens when obese people normally take small tidal volumes, but they take more number of breaths. And as a result of that, anatomic dead space increases, and therefore these people retain PCO2. Also what happens is that because there is compression on the lower lobes, there is basal atelectasis, and therefore lower lobes don't take proper part in ventilation. But because of gravity, more blood is going to go to the lower lobes, and therefore there will be VQ mismatch, and therefore there will be hypoxia. So as you all can understand, obesity actually completely messes up the respiratory system compliance. And basically this is a mechanism because of which we get obesity hypoventilation syndrome related complications. So it has been found, and we all know that patients who are obese, they have acquired leptin resistance, and we know that leptin stimulates the ventilatory system. So if there is leptin resistance, then of course there will be blunted ventilatory response to this hypoxia, hypercarbia, and therefore these patients will also have awake alveolar hypoventilation. Also because of obesity, this upper airway obstruction, therefore there will be acute hypercapnia during sleep, and therefore to compensate this, we will retain bicarbonates, and bicarbonates will become more than 27, and we all know that metabolic alkalosis suppresses the ventilatory system, and as a result of that, again these people will retain PCO2, and as I explained, because of increased mechanical load, there will be decreased respiratory system compliance, there will be increased lung resistance, there will be weak respiratory muscles, and increased work of breathing. So all these things give rise to blunted ventilatory response, and this results in chronic hypercapnia. So we know that obesity causes the whole problem. Then why is it that only some obese patients get this problem and not all obese patients? And this is quite important. It makes sense because if it was only obesity, then every obese patient had to have OHS. So again, it's quite fascinating. So we have understood that obesity induces increased demand on the respiratory system, and respiratory system needs to work harder. It triggers compensatory mechanisms so that PCO2 can be kept normal. So whichever patients who manage to do this, they will have normal PCO2, but those patients where the compensatory mechanisms fail, they are the ones who will actually get hypoventilation, and they will get PCO2 awake, which is more than 45, and these are the patients who will end up getting obesity hypoventilation syndrome. So just to show it graphically, so basically patients who are obese, they require increased work of breathing, and there are increased needs to augment minute ventilation so that they can rectify the alveolar ventilation. So if a patient who can do this, he will have normal ventilation, normal PCO2. So this patient will have only obesity, or in the night he will choke and he'll have OSA. But those people who cannot compensate, they will have hypoventilation during sleep, resulting in hypercapnia and hypoxemia, giving rise to OHS. 90% of them will have OHS with OSA during sleep, whereas 10% will have pure OHS during sleep. So I hope you all understood that why obesity predisposes to OHS and why not every obese patients get this. So if your compensatory mechanisms are good, then you can compensate and only be obese or get OSA. But if your mechanisms are not good, then you end up getting OHS. So what are the clinical features of OHS? So these are obese patients with BMI more than 30. We all know that they have sleep disordered breathing, and therefore they have all the classical symptoms. They snore in the night, there are witness apneas, they wake up in the morning not feeling so fresh, daytime drowsiness, morning headaches, they cannot concentrate, the typical symptoms of obstructive sleep apnea in 90% of these patients. But what is really important that we need to really concentrate about is that patients who have pure OSA, when they are awake, they do not complain of dyspnea unless they have another disorder existing. But patients who have obesity hypoventilation syndrome during wakefulness, in the absence of other respiratory conditions, they still complain of dyspnea. So a patient of obstructive sleep apnea who complains of dyspnea, please think that he has OHS over and above. Also, what is important is that these patients present with cor pulmonale much earlier than patients of OSA do. So basically the thing is that a lot of patients actually present late. They'll be walking, talking, looking fine, and when you see them, they have type 2 respiratory failure with low PO2 and high PCO2. However, some people actually can have acute presentation, and they present with very low PO2, very high PCO2, and the pH is uncompensated. And basically 1/3 of the patients actually present like this. They straight need to go to the ICU, and we really need to be hands-on to make sure that we can save these patients. And what is really interesting is that women, more importantly, present this way, acute on chronic, whereas males normally present as walking, talking, chronic type 2 respiratory failures. What is interesting is that these patients are often diagnosed to be having COPD, asthma. Though PFT doesn't show obstruction, we keep on giving them inhalers, and we may just give them BiPAP as a part of COPD. And we are treating the patient, but we are missing the diagnosis. Patient is getting better, but so many patients we are actually missing in our practice. On examination, these patients are plethoric. There's polycythemia because there's hypoxia, and therefore there's release of erythropoietin, which induces hemoglobin production. They will have enlarged neck circumference because they are obese, crowded oropharynx. There'll be a prominent P2 on auscultation. There's elevated JVP. Patient will have tender hepatomegaly and edema feet if they are in right heart failure. So OHS causes lots of problems. So the thing is that central nervous system wise is decreased central respiratory dive, and sometimes there'll be cognitive defect also. About the airway, because they have such a crowded airway, intubation is extremely difficult in these patients, and they have obstructive sleep apnea. About the lungs, it causes restrictive chest physiology. We spoke about it. Because of this, there's pulmonary hypertension, hypoxemia, and hypercapnia. Cardiovascular, it causes coronary artery disease and congestive heart failure. Dr. Raja and Dr. Usha have made this very easy for me, so I don't need to repeat the physiology behind it. They get central obesity, they get hypertension, diabetes, hyperlipidemia, the classical metabolic syndrome, and they get chronic inflammation. And other things are that there's difficult vascular access. Positioning of these patients is very, very difficult, and they are prothrombotic. They can get DVT and pulmonary embolism. So how do we diagnose this condition? So basically, when you see a patient who looks like an OSA, who's obese, and if his saturation on room air is 94% or less, please think this patient could be having OSA. Please note that a patient of OSA who does not have any other problem while awake will always have a saturation of 95% or more. If the saturation is 94 or less, please think there could be OHS existing. If you do an ABG, PCO2 will be more than 45, PO2 will be less than 70. Serum bicarbonates are more than 27, very, very important. This is because patient is chronically hypercapnic and there is metabolic compensation for this respiratory acidosis. Other tests are patients are polycythemic. Often they could be having hypothyroidism, so please look for thyroid and check for sugars and cholesterol because these are metabolic coexisting conditions. PFT will show restriction because of obesity. Polysomnography is very important. So we basically see there is coexisting obstructive sleep apnea along with sleep hypoventilation. And the trick or the clue is that baseline saturation is low even before they go to sleep, and there are profound desaturations going less than 80% most of the time of the sleep. If we do chest x-ray, then the lung fields are going to be kind of small because of the raised diaphragm, because the fat pushes it up, and there will be cardiomegaly because of RVH, because of cor pulmonale. And what is really important is that if they come with unexplained hypoxia, please do a CTPA because they have a high chance of getting pulmonary embolism also. If we do ECG echo, it's suggestive of cor pulmonale. We get pulmonary artery systolic pressures which are increased, and there is RA-RV dilatation. So in the OPD, when do we suspect OHS? So any obese patient, whether he has obstructive sleep apnea or not, if his unexplained awake room air saturation is 94% or less, please think of this. If he complains of dyspnea at rest, please think of this. If there are signs and symptoms of pulmonary hypertension or right heart failure, please think of OHS. If the patient has facial plethora, he looks totally red. These patients of obstructive sleep apnea don't. You might be having OHS, and a raised bicarbonate of 27 or more, please suspect OHS. Okay, so now I come to the last part about how to treat these patients. So as we know, first line therapy, weight loss, of course, because that is responsible for the entire problem. But what is really important is positive airway pressure. So this is what we need to really offer. Both these things together are the first line management. So weight loss over here has to be drastic. So for OSA, like Dr. Usha rightly told us, you require 10% weight loss. Unfortunately for OHS, 10% weight loss may not really help. For this condition, you require weight loss of at least 20 to 40 kgs to begin even talking. So of course, this is definitely difficult, but this is really gratifying because weight loss actually corrects alveolar hypoventilation, and because of this, sometimes the awake PCO2 and PO2 actually normalize. It reduces the risk of cardiovascular complications like left ventricular hypertrophy or pulmonary hypertension or right heart failure. It improves nocturnal oxygen saturation, and this is all only by correcting the respiratory physiology. So, losing weight loss would really help us. It decreases the frequency of respiratory choking during night, okay, and most important, it improves the pulmonary function. So 20 to 40 kg weight loss is difficult. So the thing is that you please encourage patient to get this, but if the patients are not achieving this, and despite putting them on positive airway pressures, if they are not getting rectified, then bariatric surgery is something that we want to definitely consider for these patients. Now we come to positive pressure ventilation. We know this, so I'll quickly go through this. So positive pressure ventilation for patients of OHS is actually lifeline. Otherwise, there was only tracheostomy, but now because of positive pressure ventilation, tracheostomy has almost become obsolete. So basically, we have certain things that we need to meet. These are our endpoints. So we must aim for normalization of PCO2 not only during sleep, but also while awake. We want the PO2 to become awake, PO2 to become normal while awake and sleeping. We want the symptoms of obesity hypoventilation syndrome to be relieved. Whether it is drowsiness or dyspnea, the symptoms need to be relieved. We want to prevent complications including polycythemia, pulmonary hypertension, right heart failure. We want to treat the underlying OSA and the central hypoventilation, and we want to improve sleep architecture and quality of sleep. So basically there are two parts. Those patients of OHS who have OSA, and these are 90%, and those patients who have central hypoventilation. So first let's talk about patients of OHS who have OSA. How are we going to treat it? So basically these are 90% patients, and how we treat OSA, we will exactly treat like this. We always start with CPAP, and what is important is that CPAP titration is a must. The thing is that we cannot, unfortunately, a lot of doctors are into this, that they just tell the patient use the auto CPAP for 5 to 7 days. They just take out the summary and they say, okay, just start using this pressure. So when you are dealing with a patient of OHS, you have to make sure that the CPAP titration is done. The CPAP actually helps the patients a lot. It improves alveolar ventilation, and because of this, the PCO2 may come down. It relieves ventilatory muscle fatigue. It augments central ventilatory drive, and it causes relief of nocturnal asphyxia and sleep fragmentation. However, CPAP doesn't help in everything. It may not always improve PCO2. It may not improve nocturnal desaturations, and one of the studies shown that 43% of the patients who had OSA and OHS, when CPAP was given to them, they still spend 20% of their sleep time in saturation less than 90%. CPAP doesn't work for all the patients, and if you start CPAP, then you need to keep on reviewing the patient from time to time. So basically, if the patient cannot tolerate CPAP, or if the patient doesn't respond to CPAP, then is the time when we move to BiPAP. So basically, BiPAP is given to those patients where despite using CPAP, the PC2 is not getting normal, or the desaturation is less than 88% and it's continuing, or they cannot tolerate. So that is the time you move to BiPAP. But I just want to repeat that the studies have shown that CPAP is as good as BiPAP, and you always start with CPAP, and only if the patient doesn't improve, then do you move to BiPAP. BiPAP has a number of advantages, that it provides with active ventilation because we are actually providing inspiratory pressure support. Also, it's better tolerated because the pressure gradient is less. There's better respiratory muscle rest, more rapid improvement of respiratory acidosis, and it also compensates for minor air leaks. But BiPAP actually has a huge problem also, which is important. So there could be patient ventilator asynchrony, which will result in ineffective ventilation. But most important, BiPAP often gives rise to central apneas and central hypoventilation, and therefore experts actually recommend that if you're giving BiPAP, then please use ST mode and keep a backup rate so that the patient does not get central hypopneas. We will not otherwise come to know, and we'll end up worsening this patient. Then we have something which is known as AVAPS. We all are aware of it. It's called average volume assured pressure support ventilation. So this is a very fancy kind of ventilation, which is combination of BiPAP and volume cycle positive pressure ventilation. So basically, AVAPS is only used for those patients where you use CPAP, you use BiPAP, you've done adequate setting, you're making sure that the patient is compliant with therapy, despite that the PCO2 remains high or the PO2 is low. That is the time you give AVAPS. So AVAPS is quite interesting. So basically the thing is that over here, we have to have inspiratory pressure, which is between a range, like say 15 to 20. Expiratory pressure is the same, and we decide how much tidal volume we want to give to the patient. So if I decide I want to give tidal volume of 500 per breath, and I've kept the pressure as 15 to 20, then the machine itself decides what pressure to reach and will deliver this volume. So basically by using AVAPS, we are making sure that adequate ventilation is going in, and therefore the PCO2 and PO2 get corrected. So initially, everybody was very excited with AVAPS, but the new studies have shown that initially AVAPS may be better, but after 2 to 3 months, the results given by AVAPS, BiPAP and CPAP are just the same, and AVAPS is much more expensive. So just because we have AVAPS, we don't really need to jump into it. Please try CPAP. If it doesn't help, then BiPAP with a backup rate. Still doesn't help, that is the time you want to think about AVAPS. And of course, we have volume cycle positive pressure ventilation. However, this is a short-term option only for people who are in the ICU. Otherwise, the pressures are so high that patient really cannot tolerate it on a long term. Now, treatment of OHS with sleep hypoventilation. So over here, we give BiPAP with a backup rate, but please note, CPAP can never be given to these patients. Please don't give CPAP to these patients. Assessing response is very important, especially in OHS patients, because this is not like OSA. Of course, OSA also assessing response is important, but over here it's far more important. So basically the thing is that after we start CPAP for the patients, we need to review the patient after 1 month. Okay? And what is really important is the patient adhering correctly? Was our titration correct? And is it really achieving the purpose? That the patient should not have now nocturnal dyspnea, patient should not be choking in the night, patient should not be waking up with morning headaches, and there should not be daytime drowsiness. If the patient has any of these symptoms, then first of all, please confirm the compliance, whether the patient is using the CPAP or not. Secondly, make sure that your titration is correct. And third, interface, make sure there is no leak. this needs to be done. This is history wise, but what is really important is how to know if we are really achieving our goal, and for that ABG, especially done in the night, is the gold standard. So if you do the ABG in the night and if PCO2 is less than 45 and if PO2 is normal, then you've achieved your goal. But of course, to do repeated ABGs in the night, it's difficult. Either you put an arterial line or you keep on poking the patient, and nobody's of course going to be happy. So instead of this, what is done is that we can do periodic awake ABGs every 1 to 3 months, and if PCO2 is fine and PO2 is okay, then the patient is doing fine and you have done a great job as the doctor. If the saturation is less than 88% during sleep or while awakefulness, then maybe something is going wrong. And also we can do ETCO2, or we can also do transcutaneous monitoring. However, it is not very reliable and therefore you can't really go by this. Sometimes patients come with acute hypercapnic failure. So the thing is that over here, you will not give CPAP. You have to use positive pressure support ventilation with BiPAP. You need to give a backup rate, but you need to make sure that patient is in a condition to take this. So patient needs to be hemodynamically be stable. He has to be conscious enough to understand what you're talking about. He has to be cooperative. The thing is that if this is there, then you give positive pressure ventilation. If BiPAP is not helping, then you give volume cycle positive pressure ventilation. If the patient is worsening, please quickly intubate the patient and give mechanical ventilation. Otherwise, he'll collapse. Intubation is so difficult anyways. You can't just wait. And also, if the patient is very drowsy, hemodynamically unstable, don't give positive pressure ventilation. Straight away, intubate the patient, give mechanical ventilation. Role of oxygen. We all are just so obsessed about oxygen being chest physicians, but for OHS, please note, oxygen does more harm than any good. And if we decide to only give oxygen, then even in a stable patient, there'll be PCO2 retention and the patient is going to end up on a ventilator. So basically, the only role of oxygen in these patients is that if while awake, if the oxygen is low, you are treating them with positive pressure ventilation. Despite that the PO2 is low, then you give added oxygen in addition to positive pressure ventilation, but you don't alone give oxygen. So you need to give positive pressure ventilation. After that also, if the patient saturation is low, then you're going to add on oxygen, but never give oxygen alone. Additional therapies like comorbid conditions, if there's COPD, hypothyroidism, please treat. Most important, don't give them sedatives. So no barbiturates, no opiates, no alcohol, no benzodiazepines, no muscle relaxants also. This is very, very important. By giving a muscle relaxant, you can actually kill a patient of OHS. Tracheostomy, now it's hardly required. For those difficult patients who just don't want to take positive pressure ventilation, you need to do tracheostomy. But what is important is that in OSA, you just do tracheostomy. In patients of OHS, in addition to tracheostomy, you have to give positive pressure ventilation, because just bypassing the airway does not help. You have to look after central hypoventilation also. So not only tracheostomy, also positive pressure ventilation, especially in the night. After doing everything, weight loss, positive pressure ventilation, doing additional therapy, after that also if the patient's PCO2 is high, then we use respiratory stimulants like medroxyprogesterone or acetazolamide. These two have been tried. If the patient benefits, continue. If the patient doesn't benefit, over 3 months, please take them off. Theophylline has not been studied for OHS. Prognosis is not great if we don't treat patients of OHS. High mortality, high morbidity, lots of cardiovascular complications like pulmonary hypertension, heart failure, IHD. And basically what is interesting is that when you give positive pressure ventilation to a patient of OHS, he will still do worse than a patient of OSA who's getting positive pressure ventilation. So despite correcting and despite doing everything correct, you are basically always struggling with this condition. And what is important is that hospitalization rates are also more in these patients, and they more often require ICU, they require intubation, and they require to be in the hospital, and they take much more time to recover. So I've given lots of information. I would like to consolidate everything in the form of take-home messages. So the definition: obesity hypoventilation syndrome, BMI more than 30, sleep disordered breathing, and awake chronic alveolar hypoventilation, which means PCO2 more than 45, PO2 less than 70 in an awake AVG. OHS is uncommon in general population, but it is highly prevalent in obese patients and patients with obstructive sleep apnea. Since we deal with patients of OSA, we better know this condition really well, because 20 to 30% of patients with severe OSA actually have OHS. OHS is likely to be a combination of complex interactions of lots of things. So we know it happens because of leptin resistance, it becomes because of upper airway obstruction, it happens because the bicarbonate's high, and most important, because the compliance of the lung is reduced because of extra fat. We should suspect OHS in a patient whose awake PCO2 is more than 45 or bicarbonate is more than 27, unexplained room air saturation less than 94, unexplained dyspnea on exertion, or patients have symptoms of pulmonary hypertension, right heart failure, and there is facial plethora. Treatment, if it's OHS with OSA, start with CPAP. If not getting better, give BiPAP, but with that ST mode and a backup rate. Patient still doesn't respond, then please give AVAPs. If at all the patient has central hypoventilation, then no role of CPAP. We give BiPAP with a backup rate in the ST mode. If the patient comes acute on chronic, then please try positive pressure ventilation with BiPAP or AVAPs. But if the patient is not responding, please quickly intubate. So supplemental oxygen alone is never given, and you add it on in addition to positive pressure ventilation if patient is not responding. Thank you.
Thank you, ma'am. Any questions? Still, I don't think any question is required. Thank you, ma'am.
Thank you. Thank you.
Thank you, ma'am. Now I invite Dr. Sonia Dalal to talk on OSA overlap syndrome with pulmonary disorders. I'm already given.
You've got my presentation. No, I had mailed it.
Yes, yes.
Big shout of thanks to Dr. Appar and heartfelt congratulations to the team. So, Mahatma Gandhi has very eloquently, said the imperativeness of an adequate sleep. And he says that each night when I go to sleep, I die. And the next morning when I wake up, I'm reborn. And same holds true for sleep in any diseases, isn't it? So I'll be talking on, the impact of sleep disorders with a stress on obstructive sleep apnea, on various respiratory disorders, with a focus on COPD, asthma, and ILD. So let us start with an obstructive sleep apnea with an overlap with COPD. What I'm going to talk on 3 points is the sleep in COPD, what is an overlap, and the treatment of sleep disorders in COPD. So what's the effect of COPD in sleep? The cough and wheezing of a COPD patient interrupts and delay the sleep. The sleep is more fragmented and there are increased arousals. What do I mean by that? Where there is a very low stage 3 and stage 4 of a non-REM and a REM sleep which is very less. And a patient who has a very severe COPD will have a subjective complaints of the sleep disorder. There is increased daytime sleepiness and a poor quality of sleep which is assessed by the Pittsburgh Sleep Quality Index. It's an increased complaint of insomnia and in the result inadvertent use of increased hypnotics. How does sleep impact COPD? There is more hypoxemia during sleep in the patients of COPD. They are more likely to die in a sleep, and oxygen desaturation in fact is more during sleep rather than during exercise of a COPD patient. So COPD and poor sleep goes hand in hand. It's like a two-way street. So what's the impact of sleep on COPD? It reduces chemosensitivity, it reduces the pulmonary function, it impairs the muscle performance and cause a systemic inflammation, hence chances of exacerbation of the COPD in sleep. This impact of COPD in sleep is it causes sleep disturbance, sleep fragmentation, low REM, and hypoxemia and hypercapnia can also cause disturbance of the sleep. What is the role of smoking on sleep? Cigarette smoking is associated with impaired sleep quality, increased risk of snoring, increased risk of sleep apnea, insomnia, daytime sleepiness, and restless leg syndrome. Let us now talk about what is overlap. So obstructive sleep apnea and COPD together is called as an overlap. So nearly 15% of the COPD patients have coexistent obstructive sleep apnea. And individually, if you have a patient of obstructive sleep apnea, the prevalence of COPD in such patients is around 7.6%. But when you have a gold stage 4 COPD, the prevalence of obstructive sleep apnea in those patients is nearly 43%. So how is it different? Overlap syndrome is different compared to COPD or OSA in terms of complications and worse prognosis. They have more respiratory failure, increased chances of pulmonary hypertension, have hypoventilation and hypocarbia, more severe hypoxemia, have a tendency to develop diabetes, obesity, and ultimately death. Overlap syndrome also has more chances of developing cardiac abnormalities in terms of the rhythm abnormalities like atrial fibrillation compared to COPD and asthma patients. So let us talk about the treatment of sleep disorders in COPD. So these are the potential therapeutic targets: the medications, the hypnotics, the cognitive behavioral therapy, the pulmonary rehabilitation, nocturnal oxygen, and positive airway pressure therapy. I'm sure Dr. Amita has taken so much into details about the CPAP, the BiPAP, the NIV. I mean, she's done my job very easy. I'm not going to go into the depth of any of the PAPs now. I'll just give you one or two slides on that. So, the theophylline has a potential to impair the sleep, but the data are still very conflicting. And the other COPD medications improve the symptoms and helps in improving the sleep quality in the patients of COPD with sleep disorder. And what about insomnia? And the odds ratio for insomnia has been very bad in respiratory disorders. And look at the odds ratio in severe airflow obstruction. It is up to the rate of 1.61, which is quite significant. However, the role of hypnotics, chronic use of hypnotics in human being is associated with a poor survival. And so, the chronic use of hypnotics is dangerous and is more compelling than the evidence that hypnotics would have any improvement in the objective outcome in case of an insomnia. And that holds particularly true for all the patients of respiratory or any other disorder, especially COPD. So any patient of COPD comes with insomnia, it is better to give benzodiazepine for a short time in an acute rather than giving them for a long term. The behavioral therapy mixed with cognitive therapy has a better role in treating insomnia in patients rather than with oral drugs, and it also has a long-lasting effect. What's the role of pulmonary rehabilitation? It improves sleep. It helps to promote and consolidate sleep. And this was the study by Solar, which was published in COPD in 2013, which says that pulmonary rehabilitation, 8 weeks of pulmonary rehabilitation improved the Pittsburgh Sleep Quality Index and health-related quality index of the patients. What about nocturnal oxygen? The target of saturation that you need to look is more than equal to 90 in any patients. So in case of modest hypoxemia, there is no role of oxygen. The NOTT and the MRC studies have recommended the use of L-TOT in those patients where the PO2 is less than 55 mm of Hg or a PO2 between 55 to 59 with the signs of cor pulmonale, and they've suggested that the survival is good in by giving a nocturnal oxygen, but even better when you give 24 hours oxygen. And they have recommended giving oxygen 2 liters per minute during day and 3 liters per minute at night. What's the role of oxygen in obstructive sleep apnea? It improves hypoxemia but does not improve apnea and hence the quality of sleep. It improves the saturation but does not improve the blood pressure compared to the CPAP. The role of nocturnal oxygen in overlap syndrome, it improves oxygenation but it causes increased apnea duration and also the rise in PCO2. So what works? It's the CPAP which works in COPD with obstructive sleep apnea or an overlap syndrome. What it does, it reduces the risk of death and exacerbation, and it also helps in improving the walking capacity. And so this is the graph which shows that the CPAP with overlap has a better survival rate than the CPAP without overlap without CPAP. If you look at the exacerbation rate, if the patient with overlap uses CPAP, has a less exacerbation compared to the one without CPAP. And this was the study which was published by Mikado in European Respiratory Journal when they did compared LTOT with CPAP and LTOT on the basis of a questionnaire, and they looked at the 5 years survival. And what they saw that the patients who used only LTOT, at the end of 5 years, the survival was 26%, but all those patients who used CPAP with LTOT, the survival was 71%. This brings us to a question, can CPAP also help in improving insomnia in obstructive sleep apnea? So this was the study done by John Doe in Sleep, where he said that patients with OSA and insomnia were evaluated before and after 2 years of giving a CPAP. The middle of the night awakening was the most prevalent kind of insomnia and which was significantly improved with the use of a CPAP. And early morning awakening was associated with a poor compliance. So it showed two things. One, that insomnia in CPAP, with CPAP in OSA patient, the middle of the night was probably the insomnia which was corrected by CPAP, but all those patients who were prescribed CPAP and not using CPAP, poorly compliant, had an early morning awakening. I'll not go into the depth of this, but NIV has a role in improving COPD. It improves gas exchange. It improves sleep quality. It reduces the need of mechanical ventilation in case of an exacerbation. It improves dyspnea and quality of life. It is also associated with improved mortality in various prospective trials, and there is still a controversy about the use of the high intensity and high pressure settings which we were discussing yesterday, Raja. There's still a controversy about the use of the same. This similar role of NIV in OHS with COPD, which improves the hospital-free days, it improves the quality of life. What's the role of bilevel? What's the role of BiPAP in OSA and overlap? Bilevel use has still not been very well studied and demonstrated in the patient of a pure obstructive sleep apnea. However, in patients of overlap, if OSA predominates, then it is always a CPAP which has to be used. But in all the patients who has an hypoventilation which is associated with obstructive events, with long sustained hypoxemia, probably there is a role of a bilevel or a BiPAP. So let us now go to asthma and obstructive sleep apnea. Way back in 1980, this is the paper from Royal Brampton, where they saw the role of the circadian rhythm on the peak expiratory flow rate. There was a drop in 8% in peak expiratory flow rate in the normal patients, but in asthmatic patient, it was a drop by 50%. But basically, it was the sleep which was having the effect on the bronchial. Can I have some water, please? It was the sleep which has the effect on the bronchial diameter, which causes bronchospasm, and not so there was a drop when the patient in peak expiratory flow rate when the patient was sleeping. But when all the asthmatic patients were kept awake, the drop in the peak expiratory flow rate was not that significant. So what explains, what happens, why does the patient have a nocturnal asthma? The probable mechanism is the circadian features as well as the sleep state induces the reduction in the diameter of the bronchus, and the possible mechanisms are the airway cooling and the supine posture, which has an effect on the bronchial diameter. The allergic factors like mites can again cause increased inflammation, and of course we know the gastroesophageal reflux and sleep apnea as one of the cause for nocturnal asthma. So Michael Al-Khalil established a link between asthma and obstructive sleep apnea in his paper, where he said that patient who has got nasal obstruction can have with asthma can be associated with the risk of development of obstructive sleep apnea. Obesity is linked with obstructive sleep apnea, and also there is an increased incidence of asthma in the patients who are obese or an overweight. And these are the established mechanisms for obesity and asthma, and these are increased atopy, altered lung development, altered Th1 Th2 balance, inflammatory cell recruitment, altered airway immune response, altered airway smooth muscles, and increased airway hyperresponsiveness, where which leads to obese patients to asthma. And this was an observational study which was published in Chest 2010, where the authors' aim was to determine whether the high risk of obstructive sleep apnea is associated with poorly controlled asthma. And what they did, it was based on a questionnaire. They gave the questionnaires to 470 patients. The two questionnaires that they had to answer was sleep disordered and asthma controlled questionnaire. And the multivariate stepwise logistic precision for uncontrolled, although adjusted for demographics, GERD, nasal obstruction, and psychiatric disorder, the odds ratio for high risk of obstructive sleep apnea was 2.85 for the uncontrolled asthma. What does this mean? What do I mean when I tell this? This means that obstructive sleep apnea is a potential contributor to overall asthma control on a much larger scale and independent of other known contributors for the asthma control. And of course we know that obstructive sleep apnea is one of the most important phenotype for the approach to difficult to control asthma. So these are some of the studies which showed the impact of treatment of CPAP on asthma outcomes with concomitant OSA. And what it showed, there was reduction in the symptoms, reduction in the bronchodilator usage, improvement in the lung function, and also improvement in the quality of life. This study shows that patient who had nocturnal asthma, in spite of optimal treatment with concomitant USA, the use of nasal continuous positive airway pressure helped in controlling those symptoms. The inclusion criteria in this patients were asthma patients who had nighttime symptoms in spite of optimal medications according to the GINA guidelines, at least one nocturnal awakening or early morning awakening by asthma symptoms, and patients who were habitual snorers. And what they saw was that CPAP improved nocturnal symptoms along with improvement in the lung functions. This paper by Laffern showed that use of CPAP in asthma with concomitant OSA improved the quality of life. And these are the physiological improvements when we use CPAP in patients of asthma with concomitant obstructive sleep apnea. I'm not going to list all those things. We all know how the physiology works. And yes, of course, the use of CPAP will help in taking care of gastroesophageal reflux, the cardiac events, it suppresses the leptin, it helps in weight reduction, and it also reduces the inflammation. So let us now talk on OSA with interstitial lung disease. What is the impact of sleep in the patients of interstitial lung disease? The respiratory rate is decreased. The stage 1 and stage 2 of non-REM is increased. REM is reduced. The slow wave sleeps are reduced. There's an increased arousal index, and the sleep efficiency is really very much reduced. So what's the prevalence of OSA, which is now gaining a lot of importance in IPF? This study, which was published in Chest in 2009, showed 44 patients out of 50 patients of IPF had an OSA. 10 patients had a mild OSA with AHI of 5 to 15 events per hour, and 34 patients, that is 68%, had moderate to severe OSA, where more than 15 events per hour. And these are various studies which have shown the prevalence of obstructive sleep apnea in interstitial lung diseases, and which ranges from 10 to 44%. So all the patients of idiopathic pulmonary fibrosis with obstructive sleep apnea should be treated. And this study, which was published in Sleep Breath 2015, shows that there were 92 treatment-naive, newly diagnosed consecutive IPF patients who underwent an overnight attended polysomnography. All those patients who had AHI of more than 15, CPAP was initiated, and then the patients were divided into a good as well as the poor compliance group. All the subjects were then subjected to multiple quality of life and sleep instrument before the initiation of the CPAP and after 1 year of the completion of the CPAP. The good CPAP compliance group showed statistically significant improvement in the quality of life and sleep instrument after 1 year of a CPAP treatment. The poor CPAP compliance group showed significant changes of smaller strength only in a minority of used instrument. What do I mean when I say that? That the 24-month follow-up period after CPAP initiation, 3 patients from CPAP of poor compliance died, but whereas all the patients from the good CPAP compliance remained alive. So in summary, I would like to say in COPD, sleep and COPD have adverse effect on each other. COPD plus insomnia treatment probably should not involve hypnotics. However, you can give for a short time in acute condition. You can think of a cognitive behavioral therapy. COPD with OSA, that is overlap, is best treated with CPAP. NIV shows promise but is still poorly studied and expensive. You can still think of a bilevel where you have overnight hypoventilation or sustained hypoxemia in spite of using a CPAP. In asthma, obesity and asthma can have concomitant OSA. OSA is an important phenotype of a difficult to treat asthma. Nocturnal asthma with concomitant OSA should be benefited with CPAP, and in ILD, prevalence of sleep apnea is increasing and is an important associated comorbidity. In the end, I would like to say this statement from Robert Frost, that the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. Thank you very much. A small change in the schedule. So we are preponing one lecture from the next session to now, and after this we are going to take lunch break.
So the next session would be by Dr. Gopal Rawal from Sterling Hospital and Sparsh Group, Ahmedabad. He's going to talk on home sleep testing, evidence so far, and Indian context. Welcome, sir.
Yeah, okay, this key is not working. First of all, hello, yeah. Sorry that I am between you and lunch and also taking topic on home sleep testing evidence. Just my first slide is obstructive sleep apnea and sleep related breathing disorder is not a disorder of pulmonologist, ENT specialist, psychiatrist. All the symptoms can involve each and every specialist. So any symptoms that patient comes with any specialty, they can suspect the sleep apnea. And this is the sleep apnea is prevalent in other disease. And these are the evidence is showing in heart failure, there is 76%, refractory hypertension, there are 83%, coronary artery disease, there are 57% OSA present, atrial fibrillation, common arrhythmia seen in the sleep apneic patients. Then in patient of stroke, it is 63%, depression also showing 45%, type 2 diabetes is 52%, and obesity 77%. So this, if you have this come across with this kind of patients, then when your therapy is not responding, you have to suspect the sleep apnea. That's the most important thing. And these are the what are the physiological perturbations and what the mechanism responsible and how the clinical outcomes come. So there is hypoxia, then ventilatory overshoot hyperoxia, then increase the sympathetic activity, change in the intrathoracic pressures, hypercapnia, repeated arousals, and reduced sleep duration, and that is affecting the endothelial and oxidative stress and leads to systemic hypertension, diastolic dysfunction, congestive cardiac failure, and arrhythmia. So what are the indication of sleep study? So after evaluating the patients, you can go for sleep study in various indications, that sleep apnea and another sleep related breathing disorder. Then patient, you are suspecting periodic limb movement disorders, narcolepsy patients, patient having nocturnal epilepsy, suspecting nocturnal seizures. In that you have to go for a sleep study. Then REM, sleep behavior disorders, unusual behavior, patient presented with unusual behavior during the sleep. Then unexplained chronic insomnia. These are certain indications in that the sleep study is needed. So now there are 4 types of sleep devices, sleep studies available, which helps how the sleep is going on and what are the changes occurs during the sleep. So first is, we all know that type 1, that is attended full polysomnography, recording with the full staging of the sleep EEG patterns, and you can increase the number of EEG leads, but by that way you can come across with the sleep related neurological disorders. But at least 7 channel is needed, like EEG, EOG, ECG, limb EEG, respiratory efforts, airflow, pulse oximetry. Then you can do the CPAP titrations, sometimes transcutaneous carbon dioxide measurements. Even the pH you can monitor with esophageal monitoring. Then type 2, it's more or less same, but it is unattended polysomnography, and minimum 7 channel is also needed, what I mentioned in the type 1. And this is the type 3, that is unattended polysomnography. You have to at least 4 channels in that, and these channels are respiratory efforts, airflow, ECG or heart rate, and oxygen saturation. And last is the unattended polysomnography with minimum 3 channels, and it includes the channels or ability to measure the following, like direct calculation of AHI or RDI as a result of measuring airflow and thoracoabdominal movement. Now what is the home sleep study? So there are so many names of the home sleep study. It's like out of center sleep study, portable monitoring, home sleep study, home sleep apnea study. So it is a diagnostic tool to diagnose the obstructive sleep apnea, and it has evolved as an alternative to the overnight study, because there are a lot of certain cost effectiveness issue, the labor required, so that comes with the home sleep study. So it's performed in the patient at home, but sometimes it can be done in the sleep center also, or sometimes in hospital, in a ward you can go with that. So done with the less measuring channels than the traditional polysomnography. And always remember, when you diagnose the patient, you have to follow certain protocols in your clinics when you are dealing with the sleep apneic patient. So you have maintained that integrity of that protocols. First, history and physical examination, certain blood tests, if needed, then electrocardiography, 2D echo, then certain referral consultation is needed, and you have to keep the certain sleep questionnaires according to your local language also. So generally we know we can go with at our center we use Epworth sleepiness scale. You are all knowing that certain situation and the chances of dosing, and according to that you have to calculate the Epworth sleepiness scale and you can predict that. Then another is the stop bank questionnaires. There reveals that how the patient having snoring, tiredness, observes apnea, then pressure changes, body mass index, age, neck circumference, and the genders. So according to that you can calculate the risk. According to the stop bank questionnaires you can calculate the risk, and you can plan that how much that chances of patient having the sleep apnea. So this is stop bank questionnaires as screening tool for the diagnosis of OSA by unattended portable monitoring sleep study. So they have done certain study, and according to that they found that if your number of stop bank scoring is increased, then the chances of that specificity of that hope sleep study is increasing. Then another is, they are little bit complicated category modified Berlin questionnaires, that category 1, 2 and 3. According to that you have to predict that this patient having the sleep apnea or not. So in Journal of Clinical Sleep Medicine, that in laboratory PSG versus home sleep study. So most of portable monitoring devices lack ability to differentiate it awake from the sleep state, because it's not involving the neurological EEG channels. So total, and another important thing is here is not a total sleep time, it's a total recording time is used as a denominator. So rather than it's called as apnea hypoapnea index, it has to be a respiratory event index, and it's sometimes it's underestimate the severity of OSA. And but nowadays with advanced several portable monitoring tests are able to estimate total sleep time by using limited number of EEG, lack of head movements and actigraphy. So now what are the indications of portable monitoring? So portable monitoring is helpful in diagnosis of OSA, but it has to be performed after proper comprehensive sleep evaluation. You should take the proper history, evaluate that patient, whether this patient having what are the probability of having sleep apnea, then you have to go for a portable monitoring. So clinical sleep evaluation using portable monitoring must be supervised by certified sleep specialist. It's not be like anybody can see the patients and then post the patient for the portable monitoring or home sleep study. So portable monitoring may be used as an alternative to PSG for diagnosis of OSA in patient with high pretest probability of moderate to severe OSA. Then you have to go for a home sleep test. Remember that portable monitoring should not be appropriate for condition having the significant comorbid medical situation like moderate to severe pulmonary disease, neuromuscular disease or congestive heart failure, and it should not be done in certain sleep disorder. When you suspecting while taking history, suspecting that this patient may have chances of central sleep apnea, periodic limb movement disorders, insomnia, parasomnia, circadian rhythm disorders and narcolepsy, then PM should not be done. And the most important thing, it should not be a general screening of asymptomatic population. It should not be used as a general screening of the asymptomatic populations. It can be done. It can be done in certain patients where the in-lab study it's not possible because of the patient's illness, there is some critical issue, illness is there, or patient having immobility, and some patient may have a safety issue. In that you can go for that. Portable monitoring may be indicated to monitor the response of non-CPAP treatment like oral appliances, upper airway surgeries, and weight loss. Certain patients are not willing for that CPAP treatment, so they opt the another treatment. So you can see the response of the treatment while doing the home sleep testing. There are certain technical consideration you have to remember for that for portable monitoring. So home sleep study for the diagnostic evaluation of suspected OSA should be performed only in the conjunction with the, as I mentioned, comprehensive sleep evaluation. An experienced sleep technician or trained provider must apply the home sleep apnea testing sensors or directly educate the patient. Here you have to educate, you have to explain the patient how to apply the sensor at home also. You can show the video of that sensor in your clinic also. So prior performing the portable monitoring or home sleep study, their consultation with the sleep specialist should be there. And all patient undergoing should be receive a follow-up therapy. It should not be like that you have done the home sleep study and the patient is not taking the follow-up. Patient has to come with the sleep specialist. Recording should be take place over at least one full night and include minimum of 4 hours of technically adequate oximetry and flow data obtained during the habitual sleep period. Home sleep apnea test can be used as adequacy of the prescribed therapy as earlier as mentioned. Then it can be used when the patient having after the weight loss or weight gain also. Now the technology of portable monitoring is at a minimum the portable monitoring record airflow, respiratory efforts and blood oxygenations. The type of biosensors that are used to monitor these parameters for in-lab PSG are the recommended to be used in a portable monitoring. The sensor to detect the apnea is oronasal thermal sensors, and to detect the hypoapnea it has to be nasal pressure transducer, and PM should be used both type of sensor there. And ideally the sensors for the identification of respiratory efforts either calibrated or uncalibrated inductance plethysmography, and the sensor for the detection of blood oxygen is pulse oximetry with appropriate signal averaging time and accommodation for the motion artifact. There are several devices for home sleep apnea testing are available, and in essence the provider should choose the home sleep apnea testing device that have validated against the PSG, utilization and oxygen saturation sensor, and measure the respiratory events with minimum of 1 airflow and effort sensors, or they can use the peripheral arterial tonometry or another validated measure of the respiratory disturbance. There is one device, I don't have that much experience, watch peripheral arterial tonometry. What does it measure? It measures the heart rate, pulse oximetry, actigraphy, patient's body positions, and peripheral arterial tonometry signal. Then the sleep staging via proper algorithm, no airflow measurement, and the snoring sensors and respiratory sensors are the optional. And these are the signals that PAT amplitude and PAT signals and the pulse. So by that way they can detect the OSA. Over 100 peer reviews studies supporting its validity and reliability. Only device validated for use in 3rd trimester of pregnancy. There is high degree of correlation with the PSG, high reliability. Failure rate is less than 1%, but it has to be contraindicated in patients of peripheral neuropathy and pacemaker. There are certain advantages of this device. It's small, easy to use for patients, low failure rate, auto scoring algorithm makes interpretation is quick, and easy chain of custody. Disadvantage is that there is no airflow measurement, no true interpretation of the raw data, and it is expensive. So in our setup, that you have to be used in a very careful manner. There are certain digital devices that have become increasingly available to consumer as a potential tool to screen the OSA. One meta-analysis of 18 study found that compared with the PSG, the device that were bad or mattress based that has a best sensitivity, but the specificity is little bit questionable, while the contactless device like smartphone could potentially detect the mild OSA with the sensitivity of 97%. Most of time when you are taking round, certain patients ask you, I have this much of AHI. So there are some smartphone, they have that kind of app is also there. An alternative classification scheme for home sleep apnea test devices has been proposed as a SCOPER categorizations. So SCOPER stands for the sleep cardiovascular oximetry position, effort and the respiration, and that categorization system provide a more detailed description of the type of physiological parameters that are being measured and how they are being measured as a traditional classification of scheme. So what are the methodology for portable monitoring is that under the auspices of American Association of Sleep Medicine accredited comprehensive sleep medicine program with policy and procedure for the sensor applications, scoring and interpretation of portable monitoring should be there, and experienced sleep technicians or appropriate trained healthcare provider must perform the application of PM or directly educate the patient. PM device must allow for the display of the raw data for the manual scoring, or you can go for the automated scoring. And evaluation of PM data must include the review of raw data by the board certified sleep specialist, and the scoring criteria that has to be consistent with the current American Association of Sleep Medicine standard. Due to known rate of false negative portable monitoring test in laboratory PSG should be performed. When you have that high index of suspicion and portable monitoring test is negative, then it has to be followed by the in-lab PSG, and the follow-up visit with the physician or other appropriate trained or supervised health provider should be performed when all patients are undergoing for the portable monitoring. These are the records that typical tracing from the 4-channel cardiopulmonary recording performed at home that showing the pulse rate, chest wall impedance, airflow and oxygen saturation. So whether we can use the home sleep apnea test for the CSA, there are very limited data available for that. No randomized control outcome data for the home sleep apnea test for the CSA. Some prospective cohort data demonstrate that type 3 home sleep apnea test identify the OSA and a CSA. And they have done, and their results showing that moderate to severe sleep disorder breathing associated with the increased mortality, and mostly that due to CSA is 48% versus OSA is 31%, and risk of death was independently associated with the hypoxic burden. Now what are the advantage of portable monitoring is increase accessibility, patient acceptance is fine, because India, I think it is increasing, more and more people are favoring for the home sleep study. Convenience, decrease labor cost, can be done for more than one night, and technologies is not required. But disadvantage, there is absence of trained technologies to correct and clarify artifact. Most of time it happens during the night, the electrodes is take off. So how to apply, patient is not doing, then it calculate like whether the patient having the real problem of OSA or not, we cannot able to justify. Then potential data loss and distortion, higher technical failure rate than the polysomnography, potential for the misinterpretation of the result due to limited data, inability to perform subsequent multiple sleep latency testing according to the standard protocol. Then sensor technology is varied, and most devices have no measurement of the sleep. So this is very good portable monitoring designing tree. So when you have a suspected obstructive sleep apnea, then you have to ask that whether this patient having high pretest probability of moderate to severe OSA is there. If no, then they evaluate for the other sleep disorder by the PSG. And if patient having that probability of OSA, then you have to look for the comorbid medical and sleep disorders. So if patient having comorbid medical and sleep disorder is there, then they have to go for a PSG. And if patient they do not have, then go for the home sleep study. And by that way you have to diagnose obstructive sleep apnea and then finally come to the treatment. There are little bit research is that was published in 2011 that does the home sleep testing impair the continuous that CPAP adherence in patient with the OSA? Yes, PAP users did not differ between those undergoing the home sleep study and in lab study, and home sleep apnea test offer the more accessible and cost effective alternative without compromising the therapeutic adherence. Then there are certain studies done with for the comparison of the laboratory versus portable sleep study, a meta-analysis. So it favors the more of in-lab study to diagnose the respiratory disturbance index. Then one study is auto-adjusting positive airway pressure treatment for the sleep apnea diagnosed by the home sleep testing. That was published in 2014 Sleep Medicine Journal, and that they mentioned that adherence is more common, increasing in the home sleep study of autopap. Then one is non-inferiority of functional outcome of in ambulatory management of OSA. So they are dividing in same number like 148 in lab and 148 in home sleep study, and they calculate certain data, and finally they found that mean CPAP use in home group is 3.49 plus or minus 2.45 hours per day, while in lab it is 2.92 plus or minus 2.32. So that favors that in home sleep study the usage of CPAP is compliance, adherence is increasing. Some data support home sleep apnea testing supporting data like watch pad earlier as mentioned is adequate for diagnosis of OSA. Certain device that measure nasal pressure and plus efforts are adequate to diagnose the OSA. But thermal sensing device alone without any efforts measurement is inadequate for diagnosis of OSA. Then our guidelines that Indian Initiative of Obstructive Sleep Apnea guidelines, INOSA, accept that portable monitoring is type 3 and 4 are useful, cost effective, convenient and speedy method of diagnosis after the careful, after the careful patient selection by the trained sleep. So patient evaluation should be done. It should not like that patient wants a sleep study and you just tell that my technician will come to your place and he will apply the sensors and then your sleep study has been done. It should not be like proper sleep study. Before the sleep study, proper evaluation should be done. Then this is the utility of our Indian study, utility of portable monitoring in the diagnosis of obstructive sleep apnea. They have searched variable available literatures with portable monitoring in OSA with filtering over the last 10 years. And they concluded with that the detailed evaluation for the pre-test probability is needed to obviate the need of level 1 and level 2 sleep study. And the published practice parameters for portable monitoring are relevant and applicable in Indian setting, and they concluded that the greater adoption of portable monitoring by trained sleep physician would be enable timely diagnosis of OSA with reduced the cost and waiting time in certain poor resource is there also. Then what are the adaptability of portable monitoring in India? In view of unexplored OSA burden, the complete sleep evaluation with portable monitoring may be acceptable. Number of trained sleep specialists needs to be increased. A lack of awareness that has led to patient being diagnosed at severe end of OSA spectrum. Pre-test probability is naturally high, favoring the portable monitoring. Use of level 1 PSG could be reserved for patients suspected having non-ASA multiple sleep disorders. Portable monitoring can be used in high-risk population to determine the prevalence of OSA. Due to paucity of sleep laboratories and trained personnel, PM can be undertaken in hospital ward also and at home also. Use of standardized equipment may facilitate the screening of more patients, and with the right device and right technician, PM can be used in resource-poor setting. There are certain limitations, as some of them I mentioned, compared with the PSG, that type 3 device do not typically detect the arousal from the sleep because of they do not include the EEG. Then as earlier I mentioned, it is a respiratory event index because it's total monitoring time, not the total sleep time. Some type 3 study do not record the position, so they may not able to detect in which position the patient having more apnea and which patient, so we can suggest the patient as a behavioral methods. Most of type 3 study cannot distinguish with the REM sleep from the non-REM sleep because of they do not include the EOG monitorings. Some home sleep apnea device cannot distinguish between obstructive and central events. So patient at risk for central apnea, hypoapnea and hypoventilation should not be tested with such device. Okay, so I'm concluding that home sleep apnea is also referred out of center and acceptable approach, and you should perform in high pretest probability having the moderate to severe OSA, and remember that should not be comorbid medical or sleep disorders, and evaluate efficacy of oral appliance, upper airway, post-bariatric surgery you can utilize, and you can use certain other methods also, and this is the ultimate diagram of portable monitoring. By that, I'm thanking to all of you. Thank you.
Any questions? Yes, sir.
So India, it's 70% people are using home sleep. Yeah. Yeah. Because of them, I am here. Yeah, we are planning to. And you are we are welcoming Apar also. I forgot to mention his name also.
Next session will start in half an hour. Lunch is arranged at CWRC basement, which is right opposite the college block. Please assemble in the same place in half an hour. Thank you.